let's go through a demo patient and show you how we went through this process. So this is a patient that came to see us that was seeking a full mouth rehabilitation. He's kind of you can look at them and see that he's invested money in his mouth over the years, but he's gotten to a stage where he just has a mutilated dentition. He has teeth failing, many teeth that are in need of extensive work, and he just wants to explore the process of removing his teeth and finding some type of fixed solution. So I'm going to share with you kind of our digital workflow. We did, in his situation, we did an analog wax up. So you can see on the left of the screen here, we captured casts and then did a wax up. Today, if he was with us, it would be intraoral scans and a digital tooth arrangement. But you can see on the top of the screen the plan that we've come up with based upon his tooth arrangement in positioning these implants and the segmented casts. We utilize an outsourcing service to fabricate and design the templates. So you can see the design of these templates are what we refer to as stackable guides. You have a seating jig that's far on the left here. It's 2 pieces. So that helps position this base in the right spot. And then once the teeth are removed, this becomes the bone reduction guide. And then we have the osteotomy guide that snaps onto that, so you can prepare the sites. And then we have a prefabricated provisional that will allow us to pick up the components there. Now, before we move forward with obviously loading these implants, we go through the process of utilizing Osstell ISQ. So this is something that we use on all of our patients. You can see that first one. I'm pulling this from the Osstell Connect information 76, and then the second implant gave us a 70. The third implant gave us a 78, and these actually I think are kind of high numbers for the maxilla. So we're very excited to see these numbers. And then the last implant gave us an Osstell reading of 80. So obviously with these in our clinical assessment of the stability of these implants, this was a patient that we proceeded with jumping the prefabricated restoration over and converting it in the laboratory for a screw retained immediate restoration. Now when we move to the mandible, not too different. We have the same type of templates, and then we have the approach that we've taken, and this one really highlights the need for the bone reduction appropriately, because this patient was not being restored with crown and bridge. This patient was being restored with a what we call an EMAX hybrid restoration, a metal framework with pink porcelain and individualized restoration, so which requires some space. Many of you would be doing monolithic zirconia restorations, which require more space. This was a dentate patient. We were transitioning to that phase, so we have to create a little bit of space for the materials we call prosthetic volume. So this patient was a 77, 71, 82, and a 75 in the Osstell reading. So very favorable positioning, and moved forward with jumping that interim restoration over. Now, some of you may be saying, well, what happens when you have an implant that doesn't have that reading? It's an implant that you don't want to load. In a situation where we're doing all on 4 like this, it gets a little difficult, especially where that implant is that we may not be loading. You can go to a shortened dental arch, but in many situations we will submerge the implants and use a prefabricated denture that is just realigned, and they leave with a removable prosthesis. And that does happen. I'm showing you a situation where the ISQ numbers were favorable and we're able to move forward with immediate placement and load of these implants. Down the road, the patient came back and we connected. Actually, at the time of surgery, the abutments were connected and the provisional was jumped to it. So now when they come back later and we're going to go through the impression making procedures, I'm not going to remove these abutments and go back to the implant level to get my Osstell reading. So we did abutment level ISQ measurements at this visit, and it's not a one-to-one relationship of the surgery, but it gives us a baseline to build on from here. Everything was cross-articulated and ready to, the master cast was verified, ready to send to the laboratory, in which we move forward with a framework try-in and then the ultimate restoration. So these are cobalt chrome frameworks with pink porcelain and individualized crowns placed on them. So the patient had his restorations delivered in February of 2020, literally right before the pandemic. And then we just recently saw him for follow-up just this past year in March. He's doing spectacular. This is a shortened dental arch. He did not want to proceed with sinus grafting and being able to extend his distal extensions further. You can see with his smile, he's not exposing any missing teeth. He's happy with his corridor and his ultimate tooth position, his smile. So this is a successful treatment, and that's how the Osstell ISQ was involved with it.